Good afternoon, dear participants, and a very warm welcome to our third talk show, Let's Talk Primary Healthcare. My name is Melita Jakab, and I am the head of the WHO European Center for Primary Healthcare. Thank you very much for joining us this afternoon. Our talk shows are now drawing an audience of 200 participants from over 40 countries, and we are very excited to join you regularly into a conversation about processes and trends at the primary healthcare level. In our last two talk shows, we looked at transformation that has been taking place in primary healthcare during the pandemic amidst growing concerns of the enormous increase in tasks and responsibilities. Last time, we discussed priority setting and demand management strategies in response to cope with this. Today, we will focus on the impact of these trends on the health and the well-being of the primary health and care workforce. The COVID-19 pandemic is placing enormous burden on those who care of us when we are unwell. Emerging research shows that there is increased incidence of stress, anxiety, depression, and other health issues. But do we really know enough about the scale and the scope of the problem? Do we really know what interventions work? And more importantly, have we learned enough lessons to turn them into policies in the long run to strengthen the resilience of our primary health and care workforce? This topic is extremely relevant because 2021 is the year of the health and care workforce. Today, we're going to start with a one-hour panel discussion, as we always do. And after that hour, I invite you to join us in two breakout sessions because we would like to hear from you, from your experience, what you have been doing to support your health and workforce at the primary healthcare level. In the meantime, please say hello to us in the chat. Share with us your thoughts, share with us your questions. My colleagues are also going to be using the chat very actively. We will be sharing with you a lot of resources today. And with that, let me introduce our panel. Morgan Lucey, National Lead for Employee Assistance Program, Health Executive of Ireland. Thank you for joining us and a big welcome. Jana Chihai, President of National Society of Psychiatrists, Narcologists, Psychotherapists, and Clinical Psychologists of Moldova. Ariel Semberov, Nurse Psychotherapist, Klalit Health Services, Israel. And then Chisholm, Technical Officer, Mental Health Program, WHO Regional Office for Europe. Thank you so very much for joining us today to talk about this very important topic. And before I turn to you, to our panel, I invite all of us to watch a video together to hear from health workers themselves.
The national journey through the first and second wave has been a roller coaster.
We need to face our emotions. So we cannot hide our emotions and to pretend that everything is good.
Не би било пријатно да зборувам за умор и за некој стрес претрпен кога некој има потреба и губи живот.
Има немили настани, неславни, неубави завршетоци на пациентите и сето тоа влијае на нас. Многу често и плачеме под маските.
I was holding a phone next to a dying woman's ear while her daughter said her final goodbyes. And that was very, very difficult for me. So I did seek some support there.
También, aunque eso ha mejorado y ya no me ocurre, pues al principio tenía muchísimas pesadillas. En un primer momento eran pesadillas relacionadas con la pandemia y con el hospital y nunca descansaba, siempre que dormía seguía trabajando, pero después incluso eran pesadillas muy desagradables relacionadas con mi familia o con muertes o algo así.
So often after the event, after things have calmed down, once people are a bit less busy, once people have a bit of time to reflect, that some of the more challenging psychological kind of repercussions of that experience come to the fore.
Lo que a mí me pasaba se repetía en otros compañeros míos y lo hemos hablado entre nosotros, porque cuando tú piensas que estás solo en algo, resulta que lo hablas con tus compañeros y están igual que tú.
You become very, very mindful of how fragile our situations really are in reality.
So how can we make sure that after the pandemic, teams are still connecting really positively. They're still spending time talking with each other. They're still spending time looking after each other in order to look after the patients that we serve.
We all knew we'd have sore hands. We knew our faces would be sore from the masks. We knew we'd be tired, hungry. A lot of us went without breaks during this time, but we had each other.
Ariel, I would like to start with you to continue with the voices from the field. You're working in a large service delivery organization in Israel. You're providing health services yourself. You're a practicing psychotherapist. What stands out for you in this video? What have been your observations about the health and workforce in Israel, especially those who deliver frontline primary healthcare services?
Yeah, it's very excited. Very excited. This video took me to the intensive care unit. One of the programs that I took part in was help for nurses in intensive care unit. So imagine this 2 meters Hercules guy working for 15 years in this unit and known as a mentally strong, physically and mentally strong guy, breaking apart after he tried to save a pregnant woman and cried with her husband after her death, leaving 4 kids. A nurse who comes back home start drinking, and more and more her husband understands that there is some problem, taking her, seeking help. So, and that's in the hospital, and also we will talk today about community health service. So it took me there, this video, was very exciting for me.
And let me stay with you, Ariel. What have been your observations regarding the health and well-being of the health workforce in the organization in which you work, Klalit Health Services? What have been the main stressors for the health workforce in your observation?
Before I start, I want to express my appreciation to all medical teams all over the world. The sacrifice, the commitment, the giving. So thank you so much, and we really appreciate it. Before the stressors, I want to take us a little bit to the background. In Israel, we recognize this wave that will come to us, wave of COVID, through our watching the heroic coping with COVID from Italy and US medical teams. We watched it with the worries and the compassion. So my appreciation to them. And we tried to learn from them, and then we came and started to search some literature from SARS 2003. Understanding that for medical teams, there were high mental consequences with secondary post-traumatic stress and depression, and anxiety, and burnout. And I think as a psychotherapist, it's important to understand not only the stressors, but what is the baseline. Then these stressors hit you. So in 2018, in Israel, we had a burnout survey, and we found out that we had, if we speaking about rates of 3 as a rate of starting rate of extreme or high burnout, our teams, community teams, the physicians were with 3.4, and nurses even more, 3.5 rate of burnout. So that's how we started in 2019 when the first COVID wave hit us. The emphasis of the stressors before the first wave was on the first place of the stressors, burnout stressors, was the difficulty to combine home and work. On second place, it was the work overload. And the third place, dealing with coping with the mortality and death, conflicts between inside the teams, and also violence, more verbal violence of clients. So that's what we knew from this survey. And by the first wave, the first stressors were operational management, logistics, physical, trying to fit the physical environment for first frontal care of the clients. And then I would divide other stressors with in three dimensions. The first one is a personal dimension that influenced by the social situation, how the social situation influencing the personal self. And there, by first close-up, when all the kindergartens and all the schools were closed and children stayed home, like background, young parents, the medical staff, and we knew earlier that they are more predictable to have a high level of burnout from age of 18 till age of 40. So they had to cope with the situation when they have to go to work and their kids are home. So besides that, they were socially isolated, no activities, no well-being. They can't see parents because the elderly parents are at home, and there is some danger of being infected. So much of stressors, much of home overload. And then the second dimension is a professional personal. I mean, how work influences the personal self. So there at work, social isolation, because people are used to be together, to eat together, talk with one another, and suddenly they're separated, they're not united, they're isolated. Lack of information. At the first wave, the clients were very appreciative for the teams and cooperative. By the second wave, everybody, all the population, were in much of anxiety, stress, and then the verbal violence came. So coping with this stress, illness and mortality, and it's important to say that 98% of treatment of COVID was at the community services, and only 2% at the hospitals. So much of the overload fell on these teams. On the professional dimension, there is once again lack of information, knowing how to treat patients in the best ways, some hopelessness, professional hopelessness, and work overload, which influenced the people's view on how professional am I. So these consequences on the emotional state of people became the stressor itself. Because when people are stressed, in tension, with depression, thinking of insufficiency, failure, and they start to be in state of irritability, sleep disturbances, and lack of attention, and so that becomes itself a stressor on the teams.
Thank you very much. That's really interesting. Morgan, let's come to you right away and let's contrast Ireland's example on this. You also have a very strong tradition of surveys of health workforce, health and well-being. What was your baseline pre-pandemic, and how has the pandemic affected that?
That's true. I give a number of examples. First of all, I'd say we have had, I suppose, a number of really useful data sets in terms of national healthcare worker staff surveys, but the recent ones are from 2016 and 2018, which when taken together give us a really good kind of give us very good baseline data on the types of issues healthcare workers were facing, some of which we've tracked through COVID as well. And I'm talking about things like specifically work-related stress, different health and well-being related issues like, recognition, workplace culture, communication, involvement, staff engagement, work-life balance, job role and demands, line management and leadership, all of those pieces. And I'll talk to those in just a moment. They're healthcare worker specific surveys, but to put that in context, also from 2018, in Ireland, the Economic and Social Research Institute reported that across the Irish health sector, workers are exposed, compared to other sectors, to the greatest number of job demands compared to any other sector in the country. And about 1/5 or 20% of health sector workers at that point in 2018 were experiencing significant job stress. And that was before COVID ever arrived. And obviously in the post-pandemic recovery phase, the impact of work-related stress is going to be greater and will continue for healthcare workers. In terms of the 2018 survey, that was called Your Opinion Counts, across all of the public sector, the Irish Health Service is essentially approximately, just to give you some flavour, some examples, 1/3 of workers at that point in 2018 said they were dissatisfied with the level of work demands on them. And I think it's a good example of a pre-COVID baseline measure that can be very usefully compared to, pieces that we've done, say perhaps in 2020. We did a very useful staff engagement survey in the National Health Service. And we can track that directly using the before and after. It's essentially one of the things, and it speaks very loudly to why we do these surveys. In the 2018 survey, one of the main takeaways was that it demonstrated very clearly that staff well-being levels are very strongly correlated to the quality of patient outcomes. And if I were to choose one thing to demonstrate the value of doing these surveys and doing them repeatedly and tracking it over time, that's what I would point to, I think.
Indeed, and I think it's a very powerful example that both Israel and Ireland have a tradition of these surveys. And you continue to do this during the pandemic, correct? Is there any additional insights that you have found that then laid the foundation later for designing interventions?
Yes, most definitely. We have a very kind of dynamic staff engagement team in our National Human Resources Division, and they did a very useful survey last year involving both a quantitative survey and then afterwards following it up with focus groups to get more qualitative data. And they looked at a range of different areas. And they focused on recognition from the organization and line management. They looked at the whole health and well-being area. Some of the issues Ariel spoke about, around safety in the workplace, PPE being available, training for line managers, communication, having the skills to help the healthcare workforce when they are under pressure. Their involvement in decision making. There were lots and lots of different areas and very concrete supports and tools to enable people to do their jobs as well. A couple of key things that they found, which have been used and are being used in terms of designing interventions, are that for people who were redeployed or ended up working remotely, there were lots of issues that came up around staying connected. And how important that was for their health and well-being and for their mental health. at times of, growing and building pressure across the health service. And I suppose one of the things that we always look at a national level is with staff working from home, we actually have very significant responsibilities on a legislative level to support their well-being needs and to make sure that we are, proactively supporting that with real concrete measures and supports. There were other things that came up around management and the scale of what was being asked of primary healthcare workers and other healthcare workers, and that how critical it was for management and leadership to acknowledge that and show, appreciation and recognition that there was a sense of a genuine thank you being offered, and how important that was for staff. Very often it's the simple things being done well that actually make the greatest difference. Ariel referenced this as well, but giving people the tools that they need to do their work, to do their day-to-day job, making sure that they have the equipment that they need, whether that's PPE or ICT hardware, particularly if people are redeployed or working from home, and how critical that is. And the whole area of, management support, and that, managers are given the training and the soft skills training to enable them to support staff in the workplace, so that they're not looking to, more systemic measures or support all of the time, but that people can do it in real time in the workplace day on day. And they're just a couple of examples. There are many, but I would encourage people to look at some of those reports if they're interested. I believe they're going to be shared in the chat.
Thank you very much. That's really helpful. Let's now come to you, Jana, to Moldova. Did Moldova also have such a good baseline and a strong tradition of surveying health and well-being of health workers?
To be honest, in the beginning of pandemic last year, Moldova was not prepared practically, only theoretically as a strategical steps. And we just think about mental health consequences as a result of pandemic. We thought about acute stress disorders. We thought about PTSD, post-traumatic stress disorders, depression, anxiety, chronic asthenia, and other problems. But also we started some modest intervention, and we provided inpatient care in terms of burnout. We expected in the frontline hospital settings through common platform of self-evaluation. To be sincere, frontline workforce was for us an important challenge. We detect after this self-evaluation platform, 80% of workforce have moderate burnout and about 40 from them severe. We developed some algorithm of intervention and mobilized all psychologists for all institutions and train them in the first psychological aid. And Moldova was not prepared to big amount of needs from the community or primary health care, to be sincere. We didn't think about. Moldova was likely, we have 40 community mental health centers, and all these centers are inside of primary health care. And that we could turn to do intervention, especially psychologists from multidisciplinary team, to provide the first psychological aid entry level. For medical professional leaders, directors of medical institutions, according to the algorithm. But just as we started to get a handle of issue of burnout in the community and primary health care, our family doctors and nurses became overwhelmed, very big, with vaccination and testing. The burden was and still is very high now on family doctors. We have to think about them.
Indeed, and this is what we are hearing from all the countries. Dan, let me come to you now for a regional perspective. We have here two countries that have a very strong tradition to follow health and well-being of health workers. And of course, that's an enormous support to design interventions. Do all countries do this systematically in our region? And are there guiding resources available for those countries that might not have this in place but would like to?
Okay, thanks very much, Melita, and good day to you and to the other panelists and all the other participants. Great to be joining. And in fact, this event today, I think very usefully extends a discussion that we started in the autumn, that also a webinar series that looked at the impacts of the pandemic on the well-being of the health and social care workforce more generally. And perhaps Maggie could post a link to that series in the chat. What of course is different about today's event is the specific and I think very welcome focus on the primary healthcare workforce, as opposed to healthcare professionals working on the ICUs or in large hospital settings like we saw in the trailer of the film that we made at the end of last year. I mean, I think one of the questions, is about whether we know enough about the impacts on the workforce, and to that, I think we actually have an astonishing amount of evidence already that does testify to the range and magnitude of the shocks and disruption that the health workforce has endured over the last year. I mean, there have been dozens of studies already conducted, worldwide. And several systematic reviews are already published, and they all point to the same thing: very high levels of stress, anxiety, depression, and associated problems like insomnia, up to 1 in 3 or 40% in some cases, particularly frontline health workers. And of course, that's due to a range of factors, not just the direct exposure, to COVID-19 and the fear of becoming infected or passing on to others, but of course, due to the massive upheavals in working arrangements and protocols and working hours. So when we think about the primary healthcare workers, I think there's less evidence out there. I think there's a lot of evidence about the workforce in overall terms, but less on the PHC workers specifically. And of course, that's a very heterogeneous group, and different workers will have been more or less affected or impacted depending on their particular working environment and the extent of community transmission and so on. But I think it's safe to say that primary health has also been on a real roller coaster because there would have been that kind of initial call to arms, so to speak, as the outbreak swept across the world. There was this massive disruption to their working practices and to their caseloads as well. I guess a flood of new information and directives. And then there was this kind of falling off in some places in the demand for services as either people stayed away for fear of being infected, or they were kind of requested to stay away in an emergency. And then, of course, returning now with the kind of mass vaccination program. So it really has been quite the roller coaster. And where I guess we don't have enough evidence is, it would be good to see a review perhaps that looks specifically at the primary healthcare workforce and to document these impacts. So, I mean, in answer to your question, I mean, there have already been a lot of surveys and they've been published, and people can see very easily the methods, the protocols that have been used to undertake those. So yeah, I think we're in pretty good shape to know what the impacts were. But we know that the real issue is about what to do about those impacts, which perhaps is what we're coming to next.
Indeed, thank you. That is the perfect segue to go to our second round. And in this first round, we have quite a clear problem definition, if a little bit somber. In this second round, I would like to focus our attention, what can we do? What have you tried? What can countries try? And let's be mindful that we have different audiences joining us today, policymakers in ministries of health, local governments, from large service delivery organizations. Probably every level can do something to improve the health and well-being of the health workforce. Then let me come back to you and stay with you a little bit. Could you frame for us the range of solutions to address and improve health worker health and well-being?
Yeah, sure. I think the key thing to emphasize is that, we all are different. We all react to adversity or work-related stress getting the life-work balance, right in different ways. So there's no kind of single solution, no panacea here, but rather a range of options that people might make use of, depending on what works for them and also on their level of need, actually. So, for many people, maybe people generally, healthcare workers, they'll have the coping mechanisms that enable them to manage stress that they have in their lives. And that could be through running or reading or relaxing with friends or family. But for others, maybe, some more guided self-help might be relevant, while others still may need to reach out for some more professional support. So a way of framing that, one that is commonly used in the broader context of mental health in emergency and humanitarian settings, and in a way we have a generalized emergency on our hands here, is the one developed and promoted by the Mental Health and Psychosocial Support Reference Group of the UN's Interagency Standing Committee. So this group, which is made up of many different partners, have done an incredible job in the last year of producing a lot of guidance and materials for countries to use in this space. And they have this kind of pyramid which goes right from meeting people's basic needs, basic services and security and safety. So it would include people's having protective equipment in this instance, through to having community and family support. And to that, I would add like peer support, so other workers, who can help each other, through to kind of non-specialized but psychosocial support. So things like psychological first aid, which can be delivered by primary healthcare workers themselves, and then finally a kind of more specialized services, counselling or consultations with a psychologist, a psychotherapist, a psychiatric nurse, psychiatrist, the sort of more specialized mental health services. So there's this kind of range moving from the individual through to the group to, organizational support as well, which might be delivered. So this provides some kind of framework or structure to think about the range of responses that could be provided.
Indeed, I think that's very helpful because it also relates to different roles of what different actors in the system can take. That's a very helpful background. And if you all look at the chat, you will see that my colleagues are copying the resources that Dan just mentioned and others mentioned previously. So against that background, let's hear what our 3 countries have done, what type of interventions they have implemented, and which have worked best. Jana, could we start with Moldova, please?
Yeah, in Moldova, we started our intervention to draw our intervention according the above mentioned WHO guidelines that Dan told us. And in fact, all the intervention we strategically put in 3 steps. We have roll out a self-screening platform I said about for burnout, anxiety, and depression for all medical professionals. We had trained the multidisciplinary team in the community centers, like we have 40 community mental health centers in all region, to be prepared to care all health professionals, but we highlight, especially for family doctors and nurses. And we have trained staff to understand the various consequences of hard work and mental health problems that they can experience. And additionally, we inform them through webinars about the ways of treating mental health issues and what treatment is best, because there are various needs as a sleep disorders, panic attacks, some depressive symptoms, and we highlight them about very sensitive points, suicidal ideation. We have very modest requests from medical staff, unfortunately, about the problems, the consequences. We think they don't have time for them, but we understand we have to be prepared and we have to provide different kind of information and solutions. We have linked this all to monitoring through the elaborated platform, and this lets us understand the scale of magnitude of the problem.
Thank you very much. Morgan, let me come to you now. In your previous intervention, you already began to talk about the foundations of your interventions. What has Ireland done, and what have you done specifically focusing on managers?
Thanks. There are a number of things that we have done. I would say, first of all, that we are fortunate that we have a good system of permanent staff support services. And I'm talking about services like occupational health, the National Employee Assistance Programme. We've our National Health and Safety function, and we have augmented those services, during the pandemic. We've rolled out new services within those. We have, we've developed extra guidance and guidelines and put additional resources into those services, some of which is specifically to guide managers on their duty of care to their staff teams and the individuals in those teams. And we also have an organizational health function, which also provides very structured interventions to assist managers in supporting teams where there are more complex issues and developing action plans that they can track over time. I would say, though, very specifically that one of our objectives was to bring together all of the staff support contributors to collaborate and support staff together. So it wasn't only the permanent staff support services. In Ireland, we developed what's called a national psychosocial framework, and there was excellent collaboration between a very wide multidisciplinary group who put together a really excellent user-friendly framework on a national basis, one strand of which was specifically for healthcare workers, including primary healthcare workers. One of the interventions in relation to management there has been specific psychological first aid training for managers. And going back to my earlier point, to equip them with the knowledge and the awareness and the skills to actually recognize when staff are in distress and to support them, and how to signpost them properly, and how to do short, brief interventions if that's appropriate. And that was, as I said, very wide multidisciplinary group comprising of, employee assistance professionals, psychology, psychiatry, social work, counselling, and a wide, other health and social care professionals as well. In some cases, we did tailored interventions for specific groups. For example, in public health, we came together because they were under such acute pressure and have been for a long time. We put together specially tailored packages for them to assist their staff groups. I'd say one of the things, and I think this is true across all jurisdictions, we've had quite a lot of emphasis on developing new online interventions. We have a tele-mental health group in the Irish Health Service who've been excellent in terms of coordinating that response and developing high quality online materials and modules, some of which are specific to managers. So we've developed some COVID specific e-learning modules to support managers, again, in helping in very real kind of concrete ways, staff health and well-being. We had a number of modules, that were designed and were there already from the staff support services on how to support staff mental health, specific guides for health service managers. And we have a very large e-learning hub where, there's a lot of resources similar to that people can access, including a special subset for managers. Yeah.
Thank you. That is very interesting. Ariel, let's come to you, to Israel now. Could you highlight 2-3 interventions that you have implemented in Klalit to support health and well-being of primary health workers? Maybe focus on those we haven't yet heard so much about. And what barriers did you face in their implementation?
All right, 2, 3. Oh, okay, I'll try. The first, we understood that the needs of the teams are to feel belong to the organization, that there is somebody who will take care of them when they take care of the population. And we started with staffing on the first wave. When people stop to come to clinics, especially something like physiotherapy, so physiotherapists and physiotherapist managers became really help us in operational management, answering population calls, and then later, and we are a small country. I'm talking about 9 billion population, about 30,000 physicians and 50,000 nurses. Last year we ran 393 workshops for managers, teaching them more or less the same that Morgan talked about, how to recognize the signs of burnout and how to help the employees, and workshops for managers to help them. 857 workshops for teams, spiritual, meditation, mindfulness. In every clinic, we have a social worker, clinical social worker, to give help and support, psychological support to teams. So those who do not want to go to a professional help can come to social worker. And we had an educational programs for social workers with the Natal organization and EMDR organization, who built a special program for the COVID period, how the program of helping medical teams. Different workshops for managers, how to manage the crisis and how to manage it like a routine and not as a crisis, and much more. So if you ask for the barriers, one more important thing, the mental health professionals built the telelines, and also every staff member could go to for 4 sessions of psychotherapy with professionals. And we have 1 in 2 weeks sessions for every staff member. And also we have one in a week dilemmas support meeting for managers in teams, and different solutions that we came with for our managers and staffs. The real barrier is asking for help, to teach the medical staff to ask for help. We really understand that, like in a plane, when you have crisis and there is an extreme situation and the oxygen masks fall down, first of all, you put a mask on the caregiver to help him to provide help to those who need this help. So we do a lot to give this oxygen first to our medical teams.
Indeed, and that reminds me of a very important issue that we discussed in the preparation of this talk show, and that is the issue related to stigma. How does this apply to health workers in particular, and what does that imply for the uptake of these interventions? Dan, let me come to you first.
Yeah, I think that's a very important point because it influences the demand for services. You can have a great mental health and psychosupport service, but if people don't turn up and use it, it's not going to have the desired benefit. And I recall, literally instances of this towards the beginning of the breaks in one country where they had done exactly that, and they only had a few, 2 or 3 users. So this is partly due to stigma. I'm afraid to say it's still very endemic in all of our societies, and that hinders people's willingness to seek help. Partly around the perceptions that people have about the causes of mental health difficulties, but many primary healthcare workers may be struggling, but perhaps don't want to admit it, at least not to others, for fear of being seen as weak, or worried that by making use of services, they're going to be somehow prevented from carrying on their duties, or maybe some other adverse or unwanted consequences. So they stay away. So of course we know that. I want to emphasize that it's a sign of strength rather than weakness to seek help, but it's absolutely crucial that issues of confidentiality and privacy, are guaranteed, and that real efforts are made to communicate this to potential users of services to partly address this issue of stigma.
So how can we mitigate? Yes, Morgan, I'm coming to you, in fact. How can you mitigate this in the design of your programs? And in Ireland in particular, what have you done? Over to you.
Well, just to pick up on Dan's point, it was very interesting listening to Dan. I think they're, very, very significant issues he's talking about. And I suppose to talk about it from an employee assistance perspective, we were very conscious of that, piece around stigma, the stigma, the perception or misperception about what it means if you are accessing formal supports like staff counselling or staff psychotherapy. And we wanted to put measures in place that would in very concrete ways, in very real ways, better enable access for healthcare workers and primary healthcare workers. We have found that some of the interventions that were put in place, the take-up was relatively low. However, with the employee assistance program, the numbers were quite high because the healthcare workers in our system associated with confidentiality. And I suppose that's really, really key. Dan mentioned it. In terms of the stigma, sometimes that space needs to be protected very actively for people and made as confidential as possible. One of the things that we did do in terms of the measures we took was at the beginning of December, we put a number of months planning into this. We launched a national awareness campaign for the employee assistance program supports. And it was specifically to destigmatize the accessing of, formal supports like staff counselling. Now, not every healthcare worker needs or wants counselling. There are a range of different supports, and that's really critical. And that would be borne out in the model of our psychosocial framework, where there's different levels of needs according to what people need at different times. But many staff do and have usefully accessed the staff counselling piece. And we have, and we're still running it actually. It's running on an ongoing basis, a national awareness campaign. We're pushing out materials every week. And we have seen an increase in the take-up rates for staff counselling as a consequence, which is a really positive thing.
Ariel, you brought up this issue. How about in Israel? What did you do to take this into account in the design of your program?
Yes, there is a real stigma to come, especially to a mental health center or to come and admit the problem. The less stigma on psychotherapy, and especially the telepsychotherapy with the telelines. And we also made it confidential and anonymous. So every worker, one from the medical staff can call this line absolutely confidentially and get help.
Indeed. So that's very important in the design. And in fact, anonymous programs are very, very important. So it seems to me that there are some very interesting common threads in the design of the programs that you have mentioned. First one is it's very important if there is a solid institutional base and a history of providing health and well-being support from pre-pandemic times. The second one is that this support necessarily needs to be multidisciplinary in nature because the needs are complex and the needs vary, and that there is a range of interventions we can think of at organization level, at local community level, and at national level, and it's very important to draw on all these resources. Now, to come to the final round, I would like us to think ahead to the medium and the long term. What have we learned from this pandemic? And what kind of policies we would like to put in place to strengthen the resilience of the primary health workforce? Ariel, let's start with you from the perspective from practice. Speaking as a practitioner yourself, on behalf of yourself and your colleagues, what kind of policies would you like to see in place?
Yes, I think the most important thing is to understand that at the time of crisis, usually the teams that are in the front line are mobilized. They're mobilizing all their strengths, and then at the end of the crisis, we're supposed to see all the breakdowns and all the symptoms of post-traumatic stress and others. So we have to be aware in national management and mental health understanding that all the consequences will come after this crisis will be over. So we have to keep our programs that we are running right now, all the workshops, but more important is not to stop it after this crisis will be ended. Right now, we are, Israel is in the first place running the vaccination. And I want to say that we are already starting to see the light, and I want to be a hope messenger for all the countries. We do see a decrease in overload, some relief on the teams, and the signs of better mood and less, I hope, less burnout. Really, as at the psychotherapy session at the end, we usually want to end with something more optimistic and less stressed. So I want to finish with this hope message for everyone.
Thank you, and certainly it is appreciated, I'm sure, by our viewers, but also by myself. Morgan, I'm coming to you. I know you feel very strongly about systemic solutions rather than ad hoc, rapid solutions at the time of pandemic. Over to you. What would you like to see in Ireland? Top 3-4 policies?
I think there are a number of things, and as you said, I think it's really key when we're talking about on-the-ground interventions. They have to be underpinned by solid systemic structures in place behind to support them. There's a couple of key things. One, I suppose, is in terms of governance. So there have been so many different disciplines, moving into the space of staff support to do something really helpful and really useful. I suppose part of our learning has been that it's really critical to have good governance structures in terms of transparency, accountability, clearly denoting who was responsible for what, and standards of care and practice for our healthcare workers. One of the things that we have done in Ireland just last week, actually, is that we have adopted the World Health Organization's Healthy Workplace Framework. It's been approved as national policy by our executive management team in the Irish Health Service, and it will be part of our national service plan. So it has been endorsed and agreed by that management team. So that will include resourcing to enable the implementation work on the Healthy Workplace Framework to begin in 2021. It's something we're quite excited about. To the best of my knowledge, the Irish Health Service will be the first national health organisation to implement the framework in its totality. And there are a number of different pillars underneath that, including the psychosocial piece that I talked about. And, it provides psychosocial risk management tools that can be used in a very concrete way in the workplace that will deliver action plans, tailored action plans to different services. So it's a really, really useful tool and framework to, help staff on the ground, but also to help organizations meet their legislative responsibilities at both the national and EU level. Another piece I would say is around health surveillance. So I think we could very, very usefully look at, what health surveillance systems are in place and, identify which subsets of those are going to be useful for healthcare workers. And I think we need to get better at doing that and look at what we're already collecting So what's there already, and you know, what we can draw from that, and then using that to identify gaps. So in Ireland, we would have adopted online systems for, say, employee assistance data, and also we are building at the moment or introducing an enhanced surveillance level through occupational health ICT systems as well, so that we can harness that data and really make it useful to our planning. The other pieces would be around doing those national health sector surveys, some of which I talked about. I think that they're really, really useful as pre and post measures. And look, my final point is this: whenever we're talking about these systemic pieces, what we need to keep, you know, foremost in the foreground is, and I want to go back to recall the video piece that we all watched at the beginning, where our healthcare worker colleagues were describing what's often known as the cost of caring, like the real impact, the human side of the human beings doing the actual caregiving. I think it's really, really important that we stay in tune with the realities of those challenges and the adversity that comes with them. In the midst of you know, us trying to implement multiple systemic changes, there's always a risk that as organizations and leaders, we can become, I suppose, slightly desensitized to the scale of continuous, relentless stress and distress being experienced by our healthcare worker colleagues. So I suppose I'm saying that in applying our new systemic changes, we have to constantly remind ourselves to first be compassionate in how we lead at the rollout of these changes, by considering what we are asking and the additional demands that these new systems and their implementation will make on the healthcare workers. It's a really, really important point. We need to consider the impact of the new systems on our healthcare worker colleagues, and that can be a source of stress as well. It's something that has been reported to us during the year about all of the positive measures that are being rolled out and the additional layers of stress that they can create. So we really need to stay cognizant of that.
Thank you, Morgan, for ending on that very inspiring and even moving thought, right? It's not just tools, it's not just systems, but really the human element and the human touch that we constantly have to be mindful of. And with that, Jana, I'm coming to you. What kind of policies would you like to see in place in Moldova in the long term to support the health workforce?
To be sincere, we have spent so much time focusing on integration mental health services into primary health care. We introduced for family doctors new mental health tasks, screening and intervention of low and moderate anxiety and depression, detect psychosis and send to the specialized services, manage dementia and autism, and screen drug users. Also, we try to introduce some psycho-emotional support for family doctors. But to be honest, but until now, it had not occurred to us because the people who work in these services will also need this help, of course. I think the burden on family doctors is very high through different tasks, testing, vaccination, treatment, etc. They have professional hopelessness. To be sincere, now we detected this in the pandemic period. They are not in a good think about their work, and we strongly need to think about them. In post-pandemic period, it will be important to think hard about how to ensure this support, encouragement, and care of family doctors, and in fact, all medical professionals. Our idea is to introduce psychologists in the center to support primary health care staff. I think it's something we like to see, especially screening, some short psychological intervention, maybe psycho-emotional support through team building, etc. And in this way, given the huge shortage of workforce, such an approach that considers the well-being of the family doctors, of the primary healthcare workforce can also be an effective level to retain and attract the new workforce, the residents in primary healthcare.
Thank you very much, Jana. Indeed, those systemic solutions are very important. And I'm looking at the time. Time is flying when the discussion is so rich and interesting. Dan, I'm going to come to you to conclude the panel discussion about thinking about systemic solutions at the regional level. Over to you.
Okay, I'll keep it brief. I think, it's a very well-worn phrase, but building back better is a good phrase, because never has there been more awareness about the value and importance of mental health, whether you're a health worker or anyone else. Everyone's mental health has been affected by this crisis. So, there is a huge opportunity to do more of the things that many countries are already trying to do pre-crisis. That includes integration of mental health into primary care and the development of more person-centered and rights-based services in the community, where dignity and compassion and confidentiality are sort of critical principles for success. But thinking about the primary healthcare workforce specifically, I see a bit of a kind of a win-win situation here. So, we talk about the integration of mental health into primary care, and we're now talking about the need to build up the capacities, in mental health and psychosocial support. So, in providing care and support to the health workforce, we're also we're kind of empowering them, and we're providing them with new skills and resources which they can use for their own well-being, but they can also then be better equipped to provide mental health and psychosocial support to their patients or clients through psychological first aid. There's the WHO MHGAT, for example. We've had some good examples of that in the region where that's been rolled out. So I see a bit of a win-win there. And the final thing to say would be that we're, of course, always looking to learn through these and other opportunities. And in fact, the regional office has set up a technical advisory group on the mental health impacts of COVID-19. Dr. Jana Chihai is one of the co-chairs. And so that esteemed group of experts and scientists will be looking at many different impacts, but of course looking at vulnerable groups and then looking at some of the most affected groups, including health workers, with a view to identifying key or critical steps that can be taken both in the short and the longer term to address the most pressing concerns and issues that are arising in countries across the region. So I'll stop there and pass back to you, Melita.
Yes, thank you very much. And indeed, that was a very swift wrap up. And with that, I would like to round up the panel discussion part of our webinar. I don't know about you, but I have learned a lot today. Clearly, this pandemic has put a spotlight on the health and well-being of those who care of us. And we have an obligation to respond to this, acknowledge the extraordinary demands that they're faced with, and act on it. But what I learned today is that to act on it requires more evidence and better evidence. And I was enormously inspired by the country cases we have heard today, that there are ways to assess health and well-being and stressors of the health workforce and to design interventions that are fit for purpose. And I think the best way to learn is to learn from country examples, and the breakout rooms will hopefully provide further opportunity to engage with our experts and with each other. But perhaps most important part of this talk show is the last question of looking forward to the medium and long term, because it's one thing, very important thing, to design workplace policies to support health and well-being. But in the long term, we have to think of working conditions, adequate salary levels, fit for purpose training, inspiring working environments. And this is an agenda that we need to all engage in and take forward for primary healthcare, as well as for other levels of the health system. And with that summary, I would like to thank our panel for your insights and sharing your experiences and your thoughts. Really a big thank you for joining us. And now we would like to hear from you. We would like to hear whether your experience is similar or different from what you heard today. We would like to hear from you what else have you tried and what has worked. We will have 2 breakout sessions, and my colleague is now pasting the link to the chat. One of the breakout sessions is in Russian language, and the other one is in English language. We will be keeping this window open just in case you're experiencing difficulties joining those breakout rooms, and my colleagues will be there in the chat to support you with technical difficulties. When we close the session, you will see a pop-out box or window with a survey where we would like you to respond to us how we're doing and suggest topics about which you would like to hear about. This survey is in 2 languages, both in English and in Russian, and it's very important for us to further design this talk show series according to your needs. Please fill it out. It takes only 3 minutes. And with this, I say goodbye to you now and see you very soon in one of the breakout rooms.